alive, broadcasting in 15 seconds.
Tamam, başlayabiliriz. Başlıyor muyuz?
Yayındayız hocam.
Tamam. Değerli katılımcılar,
Distinguished participants, I would like to welcome you all to this panel.
olduğunuz için hepinize çok teşekkür ediyorum.
I would like to thank you all for being with us in this session. I also would like to thank the Turkish Medical Association for organizing this panel. We have three distinguished panelists. We have Alejandro Argumedo, who is one of the leaders of Quechua people. We have Mr. Fuat Fuat, who is living in Lebanon, and Mr. Anwar Atallah from Palestine. I will provide more details about their background when they take the floor. We provide simultaneous interpretation into Turkish and into English, so you can listen to these interpretation service on our YouTube channel as well. The title of the session is The Invisibles. We aim to discuss the people who are invisible. We have heard the numbers of people who have lost their lives in this 1 year under the COVID pandemic. But as we discussed yesterday, the inequalities have deepened. And for those who are refugees, who are homeless, LGBTI people, and those who are internally displaced people, and also elderly people, faced discrimination. In this session, we will discuss these invisible segments of the society, and we will listen to different aspects of this topic. First of all, I would like to say a few words about this topic, especially about the refugees. I'm not sure if you can see my screen now. Yes. In this, the title of my presentation is Those Who Have Been Made Invisible Under the Pandemic. Of course, we know and we see people. The outbreaks makes the economic and class-based discrimination and differences more visible and deepen these differences. We have so many studies and research. Some of them have been mentioned yesterday. We have a meta-analysis which covers the period until early September, and there are 50 studies. 42 of them from the US, 8 of them are from the UK, and it includes 19 million patients' data. And it demonstrates that those who are Black and from Asian, Spanish background are more fragile to COVID-19 comparing to the whites. And it is the same for the Asian people from Asia. Another study shows that the outbreaks make this virus more fatal. And Black women lose their lives 4 times more than white women. As you can see here, this line shows the women who are Black, and this one shows people from Bangladesh, Pakistan, and other ethnic groups, and India, Chinese. You can see that their risk of losing their life is higher than the white women. It also indicates that outbreaks deepen economic and social differences. And also, in another study, which was conducted in Sweden in May and April 2020, it shows that those who have no legal residence in Sweden face more problems. As regards to the refugees in the world, currently 216 countries, regions, or territories have been affected from the pandemic, and 134 of these countries are hosting refugees. And there are also about 80 million people who have been internally displaced, that is equal to the population in Turkey, and 45.7 million of them are internally displaced people. 26 million of them are migrants, and 4.2 million of them are refugees. Of course,
bu pandemi sırasında sosyoekonomik nedenlerle, dil bariyeri gibi sorunlarla, düşük sağlık okuryazarlığı nedeniyle sağlık hizmetlerinden
migrants and refugees face more problems in this respect due to social economic reasons, language barriers, and also low
erişilebilir değil birçoğu için.
Literacy of health and some other reasons, and there is no access to distance, mask, soap, and water. Plus, they cannot access to information, tests, monitoring process, care services, and also vaccine. And since these groups have not been included in social services, also affect the problems. Just last weekend, I checked, as of 24th of February 2021, as you see, there are 3.6 million registered Syrian refugees in Turkey, and I'm talking about those who are related to the pandemics. And of course, all these issues indicate that there are people who are being affected. A very small amount of these people are living in camp. It is 1.8%, and the rest of the Syrian population lives in 81 provinces. Majority of them live in Istanbul, Gaziantep, Hatay, and Şanlıurfa provinces. And also there are irregular immigrants, according to the DGMM, Directorate General of Refugees Management. There is also about 1 million people who are here. According to the UNHCR, 330,000 conditional refugees, majority of them are from Afghanistan and Iraq. In total, there are about 5 million foreign people here. As regards to the health services, we have 180 health centers for refugees or immigrants in 29 provinces, and in some provinces, as we have community health services, where we have also polyclinics for foreign people. And for those who are not registered in Turkey, have no access to hospitals except for emergency cases. We have only 29 provinces with these health centers for the immigrants. And they, of course, it makes access to routine services more difficult for the refugees and immigrants. And they use public transport, and also diagnose, treatment process are becoming more difficult, particularly resulting from the language barrier, especially for those who are under temporary protection. Since these people are afraid of being deported, they do not apply to health services. And they are living in crowd areas and crowd environments, and their living conditions are not suitable for hygiene. And according to the population research back in 2018, the average household is 6 people in Turkey for these people. And there are also people who are working in temporary agricultural activities, and these people, there is a group called DOMS. They are the gypsies of the Middle East area, Middle East region, apologies, and they are living in tents or some other places which are not appropriate for hygiene. They are living in areas which are far from the living areas, and those who are under temporary protection have ID numbers that begin with 99 digits. And they can access to the services providing that they are applying to the services in a city where they are based in or where they are registered. They are afraid of being labeled, which is also a barrier to go to the health services, and they are also afraid of being fired from their job or from their house. And there is also a problem in access to masks among refugees, immigrants, and also other people in this category. And they work in jobs which you cannot work from home. And they are working in informal sector with no job security and under hard working conditions. And due to the financial difficulties, they have no access to tests and vaccines. I would like to draw your attention to the situation of women refugees, because they are living in camps, they are living in other areas where they have no access to social life, and they are subjected to domestic violence, language barrier, and also xenophobia are other factors that prevent these women from reporting this type of violence cases to the authorities, because they think that they might be deported. There are some other country cases. For example, in the UK, there is a system to report. You just need to touch upon the button. Unfortunately, we don't have detailed data and information. For example, there is a study by Assam which reached 1,162 people, and you see the percentage of men and women. You see and we have Syrians, Afghanistan, and Iraq. And when the question is, do you have information about COVID-19? It says yes. Some say yes. 64% of them say we have information. Our information source is social media. And the purple one shows the Ministry of Health, and you see the DGMM here, and which cost lines have been affected from this COVID-19. When it is asked, they say it is the bills first, and also the rent for house and fundamental needs, and some say it has not been affected. What about the hygiene? 50% of them say hygiene conditions have worsened, and some say increased. The situation of working, whether they have job or not before the pandemic, what is the situation after the pandemic, and 42% of them say we work on a daily basis jobs. And when we ask the current situation, when it is asked the current job status, 88% of them, almost 90% of them, have no job. And whether they can benefit from the health services, when this question is asked, 15% of them says there is no access, they have not benefit from the service, and 60% of them says they have not even applied. And when it is asked what is the reason, they say there is no interpretation service, there is no document. Some say we can't go out. Regarding the required measures, 78% of them say yes, we take required measures. And when the question about vaccination for children, regular vaccination for children is asked, 57% of them says yes, and 29% of them says there is no way to monitor these regular vaccination requirements, and 13% of them says relatively we can follow. There is a similar study, which is a study carried by Refugee Support Association. They talked to people from 385 households, and you can see Syrians, Afghans, Iranians, and Iraqi people. And as you see, food is the most urgent need for these people, then accommodation is following this part. When the question about the source of your information, almost 80% of them say social media in my mother tongue, and 59% of them say social media in the official language of the country. What about we don't know the measures taken and also supports which are provided. We have no information if there is any supportive materials. We also know that international organizations provide Arabic translation or Arabic materials in these refugee health centers. We don't know the numbers of tests. We don't know the numbers of cases. We don't know the number of deaths at all. We don't know the level of access to vaccines among these people. Of course, there are fundamental principles that should be observed, and these people have right to access to the highest standards of health services, and the states which are hosting these people are obliged to provide the services. That includes protection, tests, diagnose, treatment, referring these people to other required services, and also vaccination. And there is need for a health service that is based on human, that is inclusive, that respects gender, social gender, and also elderly people and children. Of course, no one is safe until we are all safe. Or, as we usually say, we will either save us from this situation altogether, or we will all lose. Now I would like to give floor to Mr. Fuat, Dr. Fuat. But before I give floor to him, let me introduce him. Dr. Fuat is a general surgeon. He is a MD from Syria, but currently he is living in Lebanon, and he is working in epidemiology and public health, and he is working as an associate professor at this university. And he is one of the 5 authorities or managers of the program. He is working on displaced people and how the crisis affects the Syrian population. Dr. Fuad also is working on armed conflict and also vulnerable groups, and also he worked on various projects either as the chief researcher or as an officer. And we know him for 3 years. We work together in this research and MENA conflict. Dr. Fuad also is a member of 2 committees of Lancet. One of them is EUBD, Lancet Syria Commission, and the second one is Lancet Migration and Health. And Dr. Fuad also is a member of Lancet and other. He has more than 70 articles in all these journals. He is also a member of the editorial board of a journal. Now I would like to give floor to him, and you can write your questions, and we will collect all these questions because we will have a Q&A session at the end of following all these sessions.
Dr. Fuad?
Well, thank you, Shafkat. Thank you very much. Really, this is very nice introduction. And I would like also to thank the, the organizers of this important conference for giving me this opportunity to join you and share some experience with you. And I think your presentation is a great introductory presentation for what I will present. So allow me now to share my my own presentation, and okay, so I will talk about the Syrian refugees in the 3 neighboring countries, Lebanon, Jordan, and Turkey. Though Shafkat covered a lot about the current situation in Turkey, the Syrian refugees, I will focus a bit on the COVID-19, but mainly I will talk about vaccination and what are the challenges facing vaccination among Syrian refugees in these 3 neighboring countries. Before going to this specific topic, as you know now, we're talking about the COVID vaccine allocation and distribution worldwide. We know now from literature that almost 75% of the 130 million doses of vaccine, of COVID-19 vaccine that dispensed as per last month, per February, these 75% of this amount have been administered in only 10 countries in the world. I mean, these countries are, as you may imagine or you can expect, these are the 10 richest countries in worldwide. Whereas at the same time, we have 130 countries that count 2.5 billion in terms of population that had yet to receive a single dose of vaccine. So no vaccine at all in 130 countries in the world that count this big number. And as we also know that there's a COVAX project, which is WHO and Gavi joint project that they promised to produce, a total of 2 billion vaccine doses to target, the third world countries by the end of 2025. Even with this 2 billion, they will not be able to cover more than 20% of the population in these countries by end of 2021. So immediately we can imagine that there is a huge disparities, between the richest countries in the world and the poorest one. And even with the best projection of distributing vaccines to the poorest countries, we will not reach a population until 2023. So when we focus a bit more on the countries that hosting refugees and displaced population, which is around almost like a 45%, 45 countries, we know that among these countries, only these 45 countries, they showed out of the 130 countries, they showed that they have a plan in their strategy to vaccinate refugees and displaced population. So not only countries that have refugees and displaced population, not all of them have this plan to vaccinate refugees. So the main issues that could affect the vaccination of refugees and host population are listed here in this slide about the issue of cost. We know now that it become more and more expensive for the poor countries. The issue of discrimination and the stigma, still there's that. We will come back to this issue about the vaccination, what they call it now, vaccination nationalism. And there's also the issue of distrust of authorities. And in some cases, like in Lebanon or maybe in Turkey, it's about the fear of disclosure of their status, because some of them have no legal status. So by disclosing themselves, that could affect their residence situation, and therefore they will not seek vaccination from the centers. But the main issue among all these reasons is the issue of lack of data. And we see that Professor Shafkat mentioned something about Turkey, but we see that in many countries, the data that's available for refugees about COVID-19 is very rare. So let's have a quick look about the situation of refugees in general and in the region. So as Professor Shafkat mentioned, that we know now, according to UNHCR, that there are 80 million refugee and internally displaced population worldwide. 25 million are refugees, means outside the political borders, outside the geographic borders, and 45 million are internally displaced, mean they moved inside the political borders. Among these 80 million displaced and refugee population, 85% of them are in low and middle income countries, which means that these countries that suffer from lack of resources, difficulties, now COVID, they receive the vast majority of burden of the refugees themselves. If we focus more on the Syrian refugees, as you now, because today is the 10th anniversary of the uprising in Syria and in the civil war. So since then, almost 6 million or 5.6 million left the country to the neighboring countries, but some even further to Europe, whereas 6.6 million are internally displaced in the country. Some of them are in close to Turkish border, and many are inside the regime-controlled territories. As per the neighboring countries, Professor Shafkat mentioned that Turkey hosts 3.6 million Syrian refugees. In Lebanon, less than a million, 800,000 refugees, and in Jordan is 660,000 Syrian refugees. But these numbers, especially in Lebanon and Jordan, are for only registered refugees, to some extent even in Turkey. So in Jordan, for example, talking about over than 1.5 million, and in Lebanon, the UNHCR, they stopped registering Syrian refugees since 2015. So the people that came after 2015 are not included in this 860,000 Syrian refugees, because that's focused only on those who are registered. I would like to pay your attention to this table, and to take a bit time to talk about these numbers, because it reflects many of the challenges that facing refugees in these countries the issue of COVID and vaccination. So as you see here, we're talking about, in Lebanon, that's almost like a 7 million in terms of population, including refugees. The number of COVID cases up till yesterday was almost like 400,000 cases. I would like you to compare that with, Jordan, which is more than in terms of population and almost the same. But even when see the Turkey, that they have, 85 million, of course, the number of COVID cases is very high, almost 3 million. But, relatively speaking, comparing with the population, the number of population, we see that it's in Lebanon is very high. When it comes to the death, we see that the total death in Lebanon is almost like 5,000, 5,200. It's 5,100 in Jordan, and in Turkey it's almost like 29,000. The case fatality rate that can tell us a bit about the severity of cases, it's almost the same, where it's a bit higher in Lebanon comparing with other two countries, and that actually reflect the capacity of the hospitals, the issue of the readiness of hospitals to receive cases, and sometimes even the issue of the healthcare in these countries. When coming to the vaccines that already started in the three countries, they have a vaccine plan, and the three countries included refugees in their plan. We see something a bit disparate or difference in these three countries. In Lebanon, for example, the percentage of people that receive the first dose of vaccine is 1.35, which is low, comparing with Jordan, that's a bit better. It's a 1.46, whereas the program is in Turkey is much, much higher. So 12% of population received the first dose. And that means, when you see the crude numbers, like 90,000 people and 150,000 people, whereas in Turkey is 10 million, almost 10 million. The problem is when we come to the refugees. As Shafkat mentioned, that the data is very rare, and it seems that this is characteristics, not just in these three countries, but also in many countries that are hosting refugees. When see, for example, the number, according to latest number, I saw it at the UNHCR, they mentioned that, only 2,900 are positive for COVID. Comparing with, we're talking about 400,000, it seems that there's something wrong here. So only 2,000 out of 400,000 are positive, are refugees positive of COVID. And only 90 out of 5,000 died because of COVID. We have no idea about how many received vaccines. When we compare that in Jordan, we see that the number that's also in the UNHCR about the number of refugees affected or positive with COVID, we saw that they have this 2,300 and only in camps. They have only numbers from people that living in camps. And in Jordan, as you may know, that only 15% of Syrian refugees are living in camps. So that means we don't know any information about how many Syrian refugees in Jordan affected with COVID outside the camps. That's the same with the number of deaths. Nothing about that in the literature. But we know that Jordan actually was generous in providing vaccine to refugees, even though we see that the data mentioned to only 234 refugees were vaccinated by vaccine, comparing with the number that received Jordanian that received the first dose is 150,000, which is, it mentioned that the number is very little. So the interpretation for that is either in these two countries, so either the number for refugees that affected by COVID is very low, or the data is actually not available. When it comes to Turkey, unfortunately, there's zero information about refugees. We have no idea how many affected by COVID. We have no idea about how many deaths by COVID, and we don't know how many out of these 10 million are refugees. So also that could reflect either there's no segregation in data, so refugees are strongly integrated with the system, or again, we don't have enough data to understand what is the mechanism of seeking healthcare in the system. So to go quickly in details with these countries, I try to understand. Lebanon is a fragmented, donor-dependent health system. Data about the pandemic, as mentioned, is extremely little and limited. And we know, but from other literature, that there are risk factors to have the virus, spread out of this population because of crowding, because of limited access to water and sanitation, hygiene, but even though observations said that we don't see a large outbreak of COVID. So the reason behind that is not very understood well. That could be because of those people are isolated, which is not, exactly right, because they can move in limited moving, but they can move. Maybe because of they are a younger age, so and also they are mostly women and children. 75% of Syrian refugees in Lebanon are women and children, or maybe, as mentioned, is about the lack of data. In Jordan, it's maybe a bit better when talking about the numbers that hosting also high number of refugees. 81%, as I mentioned, live in outside camps, but the statistics also only we got it from in camps, nothing outside. On the positive side, Jordan is the first established the first vaccination center in camp setting, which is Za'atari camp, that hosts around 80,000 refugees. Interesting to see that in this 80,000, only 234 received vaccines. In Jordan, the country that received the largest refugee population worldwide, in a study by the Turkish Red Cross Crescent, they saw that 23% of refugees, they don't feel that they receive enough information about COVID. That's because of language barrier, maybe limited access to public service. But Professor Shefkat explained well the health system for refugees in Turkey. So I will just go quickly through this now, a term that is used in many literature about what's called vaccine nationalism, where some countries and some governments, including, unfortunately, richest countries, that start talking about prioritizing vaccine access for their own citizens and deprive, or at least not prioritize, refugees and displaced population. And that's a major issue, because that will affect definitely the duration of the pandemic in these countries. So what could be a lesson learned when talking about vaccination against COVID-19 in countries with refugees and displaced populations? The main one is to strengthen the vaccination and surveillance activities, including among refugees and IDPs, integrating vaccination activities with the essential humanitarian activities, including food and medicine distribution and nutrition assessment, using technology, for example, the GIS technology, to identify those who are eligible in remote areas, and inform vaccine program planning and track migration patterns. But before and after that, it's important to focus about improving data collection, surveillance, because this is very important to understand the situation among refugees and displaced population in a country. And we'll end up with the same quote by Professor Shefkat, that's no one is protected until we all are protected from COVID. And that's, we need to invest and encourage to understand more about the situation among refugees. Thank you very much. I will stop here and happy to receive your questions after the sessions. Thank you.
Thank you very much, Dr. Fuat. Şimdi sözü ben Gazze'de halen Filistin Sağlık Bakanlığı'nda çalışan.
With your permission, I would like to give the floor to Mr. Enver Atala. who's a physicist, and he will be speaking in Turkish because
İstanbul Teknik Üniversitesi'nde
in 1996 he graduated from the physics engineering department from Istanbul Technical University, and later he completed two master's theses. One is about protection from radiation. He received this master's degree from the International Atomic Agency, and the other is a radio physics master's from France. And he also has a diploma in diplomatic relations in 2010. And now I would like to give the floor to him. Yes, the floor is yours, Enver.
Mic, please.
Sesim duyuluyor değil mi?
Mikrofonunuz kapalı.
Benim mi?
Evet.
Enver,
Tamam.
Açık
Tamam,
benim
şimdi geliyor
mikrofonum.
mu?
Yes, we can hear you now.
Evet. Buyurun. Geliyor sesim.
Evet. Hayırlı akşamlar.
Good evening, everyone.
Öncelikle hayırlı akşamlar.
First of all, I would like to greet you all and thanks for inviting me to this session. First of all, before I will talk about the coronavirus situation, I would like to tell you the current situation in Gaza. I would like to remind you of the situation. Everyone is following what is happening here in Gaza, but it is always good to remind what is happening. As you know, it is 365 square kilometers, and we have 2.3 million people, and about 70% of them are refugees. That means 1.4 million refugees are living in Gaza. Following the war in 1984, they arrived in Gaza. They were forced to live in Gaza. As you know, we have been living under siege for 15 years now, and the situation in Gaza is desperate, is extremely difficult. And all aspects of the life, particularly the health sector, have been affected at an immense level. And in this Gaza Strip, people know this situation. Both medicines and also medical tools and devices are delivered in Gaza with delays. And regarding the coronavirus situation here in Gaza, as of the end of 2019, we took some measures at the Ministry of Health level. Of course, we have suffered a lot from the siege, but the only advantage of the siege is related to COVID-19. Since our doors and borders are closed, we experience coronavirus at a very later stage. Usually those who come from outside of Gaza are subjected to body temperature. We check their bodies. Especially for those who come from China or other countries, they were put into quarantine. Since the borders are open once or twice in a month, all schools, hotels, and all other places where we used For quarantine purposes,
karantina merkezlerine alınıyordu ve
and
gününde bir PCR testi
on the third day of their quarantine, they took this PCR test,
negatif olanlar,
and those who are negative, and there were also people who were positive, and those who were positive were referred to hospitals. Thus, we had almost 0 cases until August. In February 2020, we set up National Emergency Committee, and in that committee we had Minister of Education, Minister of Health, and other representatives from different organizations, including the Chamber of Engineers, Chamber of Medical Doctors. They were all represented in this committee, and this committee serves as the emergency committee. And this committee works for 24 hours through internet, or they had some physical meetings if needed. As I said, those who arrived in Gaza from other countries were put into quarantine. And we had only one device for PCR, and we asked our engineers to repair the device, and we received kits from the World Health Organization. We repaired the PCR device, and we received 2 PCR testing kits from Turkey and 2 from Qatar. So we have 4 PCR testing kits currently. Then we had, of course, problems in ventilation devices. 2 hospitals were allocated to coronavirus. One of them is Palestine Turkish Friendship Hospital. It is a project funded, supported by TICA, and it is operating now. And these 2 hospitals were allocated to coronavirus cases. And in these 2 hospitals, there are 100 beds for intensive care and emergency cases, and 300 beds for ordinary cases. Of course, we are missing intensive care units, especially oxygen and ventilator devices currently. İHA, which is a humanitarian relief organization, and other humanitarian organizations provided some ventilation devices to us, and we had 60 or 70 before this aid. Currently, we have about 100 ventilation and respirators. Of course, we are still missing some, but due to these problems, we couldn't provide these health services to everyone, and we were about to face a crisis. As a result of this crisis, all hospitals stopped all services other than emergency services, which made the situation more difficult and worsened the circumstances. We also would like to use our laboratory, but all the equipment and also materials that we need, we consume all these materials every week, and there is need for more materials in this respect. Unfortunately, we are still missing this type of devices. Regarding the medicines, it is 40%. As for the medical devices, we are also facing difficulties. We have bought, since we referred these people to these two hospitals, and also we provided all these services at these two hospitals, the health situation has been negatively affected in Gaza. But despite all these difficulties, we are doing our best. I would like to give some figures. Currently, we have 56,000 cases in total, and there are currently 2,000 active cases, and we lost 564. That means the death rate is 1%. But we can't know the exact figure of the cases since we don't have required medical devices and also medical facilities. And since we have high population density in our territory, the virus spreads very fast. Although we had no case until August, but from 25th of August onwards, about 50,000 people were infected. I would like to move to another topic. When we registered the number of cases, we declared an emergency in Gaza. We introduced lockdown. Of course, due to the siege, the society suffers a lot from the financial issues, and because people work on a daily basis jobs, either in groceries, in markets, supermarkets, or in other daily jobs. And these people are suffering a lot and have difficulties in access to even bread, and they have no money for bread. We, as the Ministry of Health, did our best to help these people. But we couldn't help them as we should have done. We received humanitarian aid from Turkey, Malaysia, Indonesia, and we distributed all this humanitarian aid to people, but we couldn't provide all required aids, and schools were closed, and we relatively opened these schools. Kids go to school once or twice in a week. They have 50% education in schools, and 50% education is carried out in an online way and distant learning, because there is no power and there is no electricity in the territory that we are living. This is why we have been negatively affected at this level. And if, as I said before, the pandemic, we were under siege. As you know, this electricity issue, the power is a problem here. For example, now I'm using generator since there is no power at home. And if there is electricity in force for 8 hours, then there is no electricity for next 8 hours. And there are also problems in access to fresh water and water for hygiene purposes. We have difficulties in this respect as well. And the coronavirus has worsened the situation. My last point is as follows. Of course, I have two more points. As you all know, we are under a siege, under an occupation, and according to international humanitarian law, even though you are under occupation, the occupiers must provide basic human needs. Unfortunately, the occupation force in this case does not provide these needs. On the contrary, it prevents us from accessing to the humanitarian aid. Sometimes it keeps these humanitarian aids for so long at the border that we have no access. 1 week, 2 weeks, or even a month might be the period before we get the service. I would like to call on the international community. We can't hear the speaker.
Sanırım interneti kesildi.
I think he has problem with the internet
Çok
problem.
zor koşullarda.
Alo, evet, alo.
He's back,
Tamam.
he's back.
Evet, tamam.
Evet.
Evet, kusura bakmayın yine de
Apologies
elektrik meselesinde bir şey oldu.
because of the electricity and the power. As I said, occupation forces unfortunately do prevent us, and although the occupation forces must provide the services. My last point is about the vaccination. So far, 1.2 million people must be vaccinated. But so far, we have vaccinated only 5,000. We have vaccinated 5,600 people, and these people are usually working for the Ministry of Health, and some of them are elderly people, or some of them are ill people. But currently, we have a very low level of vaccination, and we will receive more vaccines in next week, particularly next Sunday.
Sanıyorum internet sıkıntısı var.
I think he has
Çok zor
a
koşullarda.
problem with his internet,
Evet.
and he is
Evet.
living under extremely difficult conditions.
Evet, tamam.
Are you
Evet,
back?
tamamlayın lütfen,
Yes.
buyurun.
Yes, the floor is yours.
Söylemek istediğimi söylemiştim, bitirmiştim.
That's all what I would like to say. Thanks for your patience. I would like to happy
Hemen size ileteyim. Belki çok zor koşullarda
to answer your
katılıyorsunuz.
questions.
Çok teşekkür
So,
ediyoruz onun için.
I will
Katılımınız
change the
için.
order and I will ask a question to you directly. There is a question for you. One of our audience says the COVID-19 services. How many health officers are there? How many health officers are there who provide health services to COVID-19 patients? So you can answer the question now, just in case there will be any technical problem in the future.
Şu anda biz Sağlık Bakanlığı'nda olarak
We as the Ministry of Health, I don't know the exact number,
doktorlar,
but
hemşireler ve
doctors, nurses, and
sayısı zaten kadro eksikliği yetersizliği
the
var.
total
Ben
number of
hastanede
staff
korona vakası
is not enough. We are facing
11 gün kalmıştım
this
babamla.
problem, I
Gerçekten kadro
stayed
yetersizliği
at the
çok vardır.
ministry for
Ama
11
gerçekten
days.
onların seviyesi çok, yani bulunanların seviyesi
But
iyi.
those who
Ama
are working
sayı
are
olarak yetersizlik var.
skillful. But we need more staff.
Çok teşekkür ederiz.
Thank you. Thank you.
Sorabilir miyim acaba?
I have a question
Ömer Bey,
as well.
merhaba. Hoş geldiniz.
Hello
Hoş bulduk.
and welcome.
Ağustos ayında başlayarak görüldü dediniz değil mi
You
korona
said the first
Gazze'de?
case was reported in August, and there was no case until August. That's correct. That's correct. And yes, there was almost zero case in Gaza until August.
Teşekkür ederiz.
Thank you,
Tekrar, Enver Bey. Ben
Mr. Anwar.
Sizlere son konuşmacı
Now I would like to introduce our last panelist, Mr. Alejandro Alimedo. He is one of the leaders of Quechua people in Peru. He studied agriculture in Canada, and he works as an activist in Amazon area, and he works for the right of seeds and the agriculture for local people, and he works for biodiversity and also biocultural rights of local people, and he is a member of the association called Andes, and he is struggling against he is a member of a foundation that works for the rights of local people, and he is a member of several international organizations, and he works as a consultant for international organizations.
Buyurun. Floor is yours. Mr. Alejandro, we couldn't hear you.
Hello, do you hear me?
Yes.
Yeah, I'm very sorry about it. I thank you very much for this opportunity. I would like to thanks the organizer of this important meeting. I acknowledge and recognize that this is an issue that it's of importance worldwide. But what I'm going to do myself is take you to the other side of the world where indigenous peoples live. So my presentation is going to focus on indigenous peoples, particularly from the Andes and Amazon region. But to begin with this, I would like to start by telling you a little bit who are those indigenous peoples. There are 370 million indigenous peoples in the whole world. It's only 5% of the population, but they hold 18% of the land. And that land that goes across 70 countries, from the Arctic to South America to the Pacific, are lands that are still pretty much conserved. They are biodiversity hotspot. There is very little impact, and therefore those lands are in the eyes of the big corporations. As we know, this issue has just magnified or amplified all these inequalities in the world, the racism, how the economical and social inequalities always go to the people that are at the lowest part of the social ladder. How this has compounded climate change, has compounded the economical crisis that we are living, and also the food crisis that is looming and pretty much facing indigenous people. Now, in all these countries, indigenous peoples are usually the extreme poor. Wherever they live, if they live in the rural areas, when cities, they usually are located in isolated places where there is no services, especially healthcare services. And because of these lands are repositories of natural resources, there is high incidence of human rights violation. And coincidentally with COVID-19 pandemic, indigenous peoples have started to feel more threats than before, because their lands have become the focus of land grabbing, mining exploration, oil exploration, or all types of resource extraction, which is taking advantage of this crisis. In most of the countries, indigenous peoples don't have land rights protection. They live under their own disproportionate, marginalization, and they are forcefully displaced because of development, and the mortality rates are triple in terms of this pandemic that we are facing. The issue of land, it's very important in terms of the pandemics. We know that this virus jumped from animals to humans because of expansion of industrial agriculture. There's more evidence associated to it. So deforestation and land degradation are very much related to the COVID pandemic, but also are related to the way indigenous peoples live. Now, we have to underline here that indigenous peoples are recognized because they don't separate themselves from nature. They are considered themselves part of nature, and therefore they have big respect and reverence for Mother Earth, for nature. Indigenous peoples in the Americas, particularly, have experienced pandemics from the past. This European invasion of the Americas in the 1400s, 1492, brought different types of infectious diseases: smallpox, bubonic plague, chickenpox, cholera, the common cold, diphtheria, influenza, malaria, measles, a whole set of diseases that indigenous peoples didn't have. And when they were exposed, we were subject to extermination. For instance, when the Spaniards arrived in Mexico, in less than 10 years, 27 million people died. In Peru, in the land of the Incas, where I come from, In 10 years, there was more than 25 million people that died with this first encounter with different types of diseases. This disproportionate effect of indigenous peoples have continued. At the last pandemic in 1980s with the influenza, indigenous peoples in North America were almost wiped out. They were disproportionately impacted by this latest pandemic. Today, it's similar case. Indigenous peoples are more affected than the rest of the population in most countries. The ratio is 3 to 1, mostly, the average population, even though we are a small number of population. And in some countries like Brazil, COVID-19 is being used as a weapon against indigenous peoples. They purposely go where indigenous peoples are isolated and bring the miners and the landlord, the loggers and the ranchers. They are taking the disease so they can take over the land of indigenous people. So it has become a weapon against the resistance that indigenous peoples have. Now, there's many impacts that indigenous peoples are experiences. There is no health that is bioculturally or culturally appropriate. Indigenous peoples do not usually go to the hospitals or to Western medicine. They mainly depend on the forest, on the medicinal plants, on traditional medicine, but without land and without access to land, the issue of water and the issue of medicines and food becomes a big problem. The encroachment on the indigenous land is resulting in loss of livelihoods because people depend on nature, and that's the pharmacy, that's the supermarket, that's the labor market. So without that, the mortality has increased very much. There's a rising food and land insecurity in many places. There's more human rights violations. There's more racism and xenophobia and gender discrimination because indigenous peoples are different. They are not accepted by the majority of the society. And because of their own worldview that sees nature as sacred, that sees nature as part of the whole world and not separated from the world, then marginalization and dismissal of that knowledge they have is very common. Also, there is a criminalization of human rights defenders. There is easing of environmental regulation in most of the countries. So mining can go forward, oil exploration can go forward, but people cannot work. So there's, and anybody that protests against those things are hauled into account by the national government. That is creating a forced migration and people detachment from the land. But at the same time, indigenous peoples are resilient. They have resisted other pandemics, and all that knowledge and those traditions have been used to fight COVID-19. They very quickly closed their lands. They instituted themselves lockdowns. They know how to separate themselves from missionaries, from miners, from loggers. So they know how to isolate themselves. And they have very good knowledge of traditional medicines that many of those have shown promise of fighting the virus. We depend too much in corporations, depend too much in Western medicine, depend too much in big food and seed corporations. And what indigenous peoples do is fight against that and try to live a more separate type of lifestyle that can respond to those crises. So let me show you some of the examples of what people are doing in the Americas, particularly in terms of COVID. First, there is the responses on traditional medicine. You know, the Amazon rainforest is the most abundant greenhouse on the planet. It has like more than 800 plant species. And from this forest has come at least 20% of all drugs that now modern medicine uses. And there's many more medicines that people are trying now in the face of COVID. For example, people are preparing what we call matico, which is an anti-inflammatory plant that people take as a prophylactic. So taking matico and getting your body prepared for any case of possible infection, it's a traditional way of how people have been responding to and diseases like flus, colds, so that type of thing. So there's the knowledge that people have about respiratory problems, the knowledge that people have about strengthening the immune system, the knowledge that people have about how to use those type of plants now are being used. Same thing, there is tribes that have declared the territories as natural hospitals. This is the case of the Wampi in Peru that went to the national government and said, this land is a hospital, this land is a pharmacy, so we need more autonomy, we need recognition of our rights so we can keep this hospital and this pharmacy for the health and the well-being of our people. Same thing, there is responses in terms of food, localizing the food, having access ready to food, depending on native crops that have high content, nutritional content, antioxidants, all types of qualities that provide people with strengthen the immune system, and they don't have to go to the cities to buy food. They have plenty of food, and their own rituals in terms of having respect for food have made them more stronger and resilient. Actually, indigenous peoples are taking food to give to city people that do not have access to food. So people practice this old, solidarity relationship with other people, helping them to overcome the crisis that we have now. They have also strengthened traditional ways of solidarity economy, like bartering, where money is not necessary. So you can exchange bananas for potatoes, or oranges for quinoa, or lentils, or maize. So there's different ways indigenous peoples trade and exchange food that they don't have, so they can have a more diversified diet that helps them with the health and with nutrition of the kids. This has grown. Now, other types of non-monetary practices that are practiced by indigenous peoples are becoming also important for city dwellers. Land defenders, more and more indigenous peoples are receiving support to defend the land, because defending the land means defending water, defending medicinal plants, defending, the balance of the earth, so climate change is mitigating. So there's no more carbon, less carbon is emitted outside, and we can keep our earth in a more healthy way. So they're leading the defense of the land, they're leading the defense, even though last year during the pandemic, more than 331 land defenders were killed. What to do? I think we can promote more holistic health systems, not depend only of Western system and medicines. We all have ways of using medicinal plants. We have to support the land rights of all peoples, and because we depend on the lands, and when there is this type of crisis, food and medicines are in the land, and the health of humans are associated to the health of the environment. We have to promote economies that are work more friendly with nature, and are have less impact on nature, and support communities with the necessary equipment so they can face this pandemic. Human rights is important for all peoples. In the case of indigenous peoples in this part of the world, in the Americas, the human rights conditions are very barely, pretty much there's abuses, so that requires also support. Thank you very much.
Thank you. Thank you very much, Alejandro. Bizim şu anda daha sonradan Enver'e sorular geldi. Ben onu
I just received some questions for Enver. With your permission, I would like to first of all ask the questions to Enver. We have already exceeded the time. However, there are some immediate questions, burning questions, and it will be great, by the way, if we could have all the speakers on the screen, and if you could end the slideshow. Let me just start with Enver's question. So, how are you planning to receive the vaccination, and is there any limitation for people who are willing to leave Gaza? Enver, thank you. Yes, I heard you. Now, earlier I had talked about this. So far, only 506 people had access, but we need 1.2 million vaccines. We need vaccines for 1.2 million people. Already there's a blockade against Gaza, and we've been living under this blockade for the last 15 years, and we cannot leave Gaza. So unfortunately, we cannot go to Egypt, or we cannot go to any other country. So it was 5,600, the number of those who were vaccinated. So we are basically living in the largest prison in the world. That's why we are waiting for donations. We're waiting for vaccinations. The World Health Organization is trying to help us, and but we do not know to what extent that help will be available to us. So this is all we know now. We have some figures, but still, I'd like to say that we received some vaccines from Russia. Of course, there had been debates whether the Russian vaccine is good or not, and we fear that there may be certain negative effects, but we did not want to use them in Gaza because the World Health Organization has not licensed that vaccine yet. Currently, from the Arab countries, from Turkey, and from other friendly nations, we are expecting some help and support. We expect those countries to send us those vaccines. And I do hope that Israel will not prevent those donations to reach us. You all know about the political situation. And so about the vaccine situation, this is all I can say. So thank you very much. And there's another question. This time it's for Fuat. And in general in Syria, and especially in the northeast Syria, about the vaccine and about the epidemic, what is the situation? Could you give us some information on that matter? So that's the question.
Well, thank you. Thank you for this question. Yeah, the actually northwest and northeast, and especially because the question is northeast, the area that's now under the Kurdish militia. I think the situation is also quite unacceptable. Although they have a sort of a plan for detection, but the data still unavailable. They start receiving vaccines, but also there's no data on that issue. The main problem now inside Syria is this dismantle, this fragmentation of the health system inside the country between different powers, to say it in that way, and there's no central information. WHO has a cluster, what they call it, health cluster there, and they collect some information. We hope that we will get a report soon from northeast Syria. Thank you.
Evet. Teşekkür ederiz. Yine Enver'e
Thank you. There is another question that goes to Mr. Enver.
pandemi ilan edildi biliyorsunuz.
As you know, the World Health Organization declared the outbreak as pandemic in March, but you said there was no case until August. So what is the reason for having no case until August? That's the question for you. Mike, please.
Ses kapalı.
Sesi kapalı galiba.
Evet. Yok test yapılmadığı için değil de biz
It's not because there was no testing, but it was mainly because we were living under embargo and it was not easy to enter or leave Gaza. And there are only two gates. One is Rafah, and it was open once or twice in a month. And those who arrive in Gaza were put into quarantine when the Rafah gate was open.
Ses koptu yine.
Connection problem again.
İnternet bağlantısında sorun olduğu
Due to the internet connection problem,
erişimi sıkıntılı.
we have difficulties in receiving the answer.
Enver Bey,
Mr. Enver?
Evet.
biz
Ya kusura bakmayın.
duyamadık biz sizi.
İnternette bir problem var.
Apologies for the internet connection. As I said, doors and the Rafah door was open once or twice in a month, and usually we received 1,000 or 1,500 people from this gate, and we put them into quarantine. But when the virus was detected in August, it spread over the community, and Before the period of August, people were put into quarantine. That is why we didn't see these cases. Of course, we asked people to take 2 tests before they entered into Gaza. And those who were positive were referred to hospitals. And as I said, it is the only positive aspect of the embargo that we have been facing. There is another question for Mr. Alejandro Arquemedo. Your presentation was really interesting. What is there any vaccination for indigenous people, and what is the situation of anti-vaccination among indigenous people? Yes, the floor is yours.
Can you please repeat the question?
The question is the vaccination level among indigenous people and also anti-vaccination. What is the situation of anti-vaccination? If there is any anti-vaccination among indigenous people, can you provide information?
I'm sorry, I lost sound, but I guess the question was if indigenous peoples are getting vaccinated.
So the question, Mr. Alejandro,
no,
the question is...
There's no vaccinations for indigenous peoples. There's in Canada and the US where there's more, I think, indigenous peoples have been placed as vulnerable, along with a vulnerable population, so they have priority. But if you go to Brazil or South America, indigenous peoples, or Central America, from Mexico down, there's no effort in terms of vaccinating yet indigenous peoples. Thank you.
Çok teşekkür ediyoruz.
Thank you. And we are running out of time, so there is no more question. I would like to thank you all for your contributions to this session. You made extremely important contributions to our session. To conclude, I would like to say we heard cases from different countries. So the objective is not to survive and overcome the COVID-19. It is also important to overcome and eliminate inequalities. It is important to build a new world with no inequalities. That should be the objective.
And thank you very much to all of you for your excellent and valuable contributions. Ben Türk Tabipler Birliği Başkanı
I would like to give floor to Professor Dr. Şebnem Korur Fincancı for her closing remarks. Thank you, Şevkat, for being the moderator. Especially in your opening remarks, you shared valuable points. I also would like to thank our panelists, Mr. Fuat, Mr. Anwar, and Mr. Alejandro. They clearly defined the issue of invisibility and those who are invisible under the pandemic, for those who are living under occupation, those who are living under armed conflict or under other parts. When a country is divided into parts, what is the price to pay? I would like to thank them all for their contributions. I would like to thank them on behalf of my organization, the Turkish Medical Association, and I would like to thank them for making visible what is invisible. As my colleague stated, the visibility and invisibility issue is extremely important for the society and also for the physicians. We listened to you and we learned what to do. And the former Executive Council issued a statement of which title is "War is a Public Health Problem." From our perspective, those who are waging wars are the criminals and are the responsibles. I also would like to thank our chamber in Bursa province on the occasion of 14th of March. I was late because of this event. I also would like to thank our interpreters for their efforts. And I also would like to thank our technical team, our colleagues Çağlar and Sinan, for this smooth session. Thank you all. Thank you all.
Thank you. Thanks a lot. And thank you for the interpreters. It was excellent.
We are
Thank you.
grateful to you all.
Thank you.
Thank
Have a
you
good
for
night.
being
Thank
here.
you very much for
Bye
all.
bye.
Çok teşekkür ediyorum hepinize. Hayırlı akşamlar.
Şükran.
Good evening, everyone.
Good evening. Bye-bye.
Good evening.